Today we will be looking at the topic of congenital adrenal hyperplasia, or CAH for short. As this is a very broad topic, the focus today will mainly be on 21-hydroxylase deficiency, CAH. The learning objectives of this presentation are: firstly, to review normal adrenal steroid biosynthesis, as this forms the basis of our understanding of CAH. Secondly, to understand the pathophysiology of 21-hydroxylase deficiency CAH in particular, which is the most common form of CAH. To appreciate the spectrum of clinical presentations of 21-hydroxylase deficiency CAH, which differs in males and females. To know how to investigate patients suspected of having 21-hydroxylase deficiency CAH. And finally, to understand the principles and goals of management. This is the outline of my presentation. I will first give a general introduction to CAH. Following that, we will review the pathways and enzymes involved in normal adrenal steroid biosynthesis. We will then take a closer look at the pathophysiology of 21-hydroxylase deficiency CAH and see how this results in its classification and its varying clinical presentations. We will run through the investigations needed in its diagnosis and go through basic principles of management of 21-hydroxylase deficiency CAH. So, what is congenital adrenal hyperplasia? CAH is a group of genetic disorders that arise due to enzyme deficiencies that result in impaired adrenal steroid synthesis. They are transmitted in an autosomal recessive fashion, and different enzyme deficiencies result in distinctive clinical phenotypes. The most common is 21-hydroxylase deficiency, which is found in more than 90% of cases, and occurs in about 1 in 15,000 newborns. This enzyme is encoded by the CYP21A2 gene. Other less common forms of CAH include 11-beta-hydroxylase deficiency and 3-beta-hydroxysteroid dehydrogenase deficiency, amongst others. The clinical manifestations of the different disorders are due to diminished production of cortisol and, depending upon the site of block, decreased or increased production of mineral corticoids and androgens. Let's first review the pathways involved in normal adrenal steroids biosynthesis. You will recall that the adrenal cortex is responsible for the synthesis of mineral corticoids, glucocorticoids, and sex steroids, all arising from a similar precursor, pregnenolone. Pregnenolone is first converted to progesterone by the enzyme 3-beta-hydroxysteroid dehydrogenase, which is then converted into deoxycorticosterone by 21-hydroxylase. Subsequent enzyme action eventually results in the production of aldosterone, the main mineral corticoid. At the same time, pregnenolone and progesterone are converted by 17-alpha-hydroxylase to 17-hydroxypregnenolone and 17-hydroxyprogesterone, respectively. 17-hydroxyprogesterone is then converted to 11-deoxycortisol by 21-hydroxylase, and subsequently to cortisol itself. And this is the glucocorticoid pathway. The third pathway, which results in the synthesis of sex steroids, is yet again a result of the further conversion of 17-hydroxypregnenolone and 17-hydroxyprogesterone to DHEA and androstenedione. Subsequent enzyme activation results in the production of testosterone and dihydrotestosterone, which are responsible for virilization. What happens in 21-hydroxylase deficiency then? We see that deficiency of this enzyme can directly affect both the glucocorticoid as well as the mineralocorticoid pathway. The defective conversion of 17-hydroxyprogesterone to 11-deoxycortisol in patients with 21-hydroxylase deficiency results in varying degrees of cortisol synthesis as well as aldosterone synthesis. The reduced cortisol production stimulates increased corticotropin or ACTH production from the pituitary gland, and this promotes adrenal cortical growth, causing adrenal hyperplasia. Steroid precursors accumulate directly proximal to the 21-hydroxylase block, and this is seen as high levels of 17-hydroxyprogesterone, which is then shunted into the androgen pathway, resulting in increased androstenedione and testosterone levels. CAH is clinically classified into three phenotypes: the two classic forms, salt wasting and simple virilizing, and the non-classic form, also commonly known as late-onset CAH. These phenotypes are a reflection of decreasing severity of 21-hydroxylase deficiency based on the degree to which the mutations compromise enzyme activity. Because the mineralocorticoid pathway requires minimal 21-hydroxylase activity, mineralocorticoid deficiency is a feature only in the most severe form of the disease, the classic salt-wasting form. In the simple virilizing and non-classic forms, mineralocorticoid production is adequate. With regards to androgen exposure, in both classic forms, excess exposure occurs prenatally, but in the non-classic form, hyperandrogenism is only noted postnatally in childhood or adolescence. The diagnosis of classic CAH is not difficult in female infants as they demonstrate virilized external genitals at birth. Male infants, however, do not have overt signs of CAH except variable and subtle hyperpigmentation and penile enlargement, which can be easily missed. Males with the salt-wasting form, who are not identified by neonatal screening, can present in salt-losing crisis, with failure to thrive, dehydration, hyponatremia, and hyperkalemia, occurring typically at 7 to 14 days of life. Males with the simple virilizing form may present with early virilization in their toddler years. With regards to the non-classic form, in both males and females, hyperandrogenism during childhood often leads to early puberty and sexual precocity. The resulting rapid linear growth accompanied by premature epiphyseal maturation and closure also results in a final adult height that is typically below that expected from parental heights. In adolescent females, hirsutism and menstrual irregularities may also be the presenting symptoms of these forms of CAH. The biochemical diagnosis of 21-hydroxylase deficiency CAH is based on finding elevated levels of the steroid precursor directly proximal to the 21-hydroxylase block. Therefore, a very high random sample of 17-hydroxyprogesterone is diagnostic of classical CAH. These levels may, however, not be elevated in the non-classic form, but may only rise after stimulation with synthetic ACTH. Other important investigations include looking for decreased sodium levels, elevated potassium levels, and acute renal failure, which would be suggestive of salt wasting and necessitate immediate management. Low levels of cortisol and elevated androstenedione and DHEAS further help in confirming the diagnosis of 21-hydroxylase deficiency CAH. The management goals differ whether the patient has got classic CAH or non-classic CAH. These are some of the principles in classic CAH. First goal would be to correct cortisol deficiency with glucocorticoids, and this also suppresses ACTH overproduction so as to reduce stimulation of the androgen pathway and thereby reduce virilization. In salt-wasting CAH, remember that replacement of mineralocorticoids is crucial so as to prevent a salt-wasting crisis. And in females with ambiguous genitalia, surgical repair during infancy is often recommended. Management in non-classic CAH differs in that treatment is recommended only in individuals who have symptoms or signs attributable to androgen excess. And these include children with advanced bone maturation, adolescents who have irregular menses, acne, or hirsutism, and in adults who have patient-important hyperandrogenism or infertility as a result of this condition. Here's just a quick note about glucocorticoid replacement. Hydrocortisone is the glucocorticoid of choice in children. It is short-acting and therefore has less adverse effects on growth and bone maturation. When final height is attained, longer-acting glucocorticoids such as prednisolone or dexamethasone may be used. And the dose of glucocorticoids is titrated according to the 17-hydroxyprogesterone and androgen levels. It is important to note that overtreatment needs to be avoided so as to prevent iatrogenic Cushing syndrome. So in summary, congenital adrenal hyperplasia is a group of autosomal recessive disorders that result in enzyme deficiencies that impair normal adrenal steroid synthesis. 21-hydroxylase deficiency CAH is the most common form, the hallmark of which is an elevated 17-hydroxyprogesterone level. The severity of enzyme deficiency influences the clinical presentation, which can range from life-threatening salt-wasting classic CAH to non-classic CAH. Diagnosis is crucial in order to prevent life-threatening salt-wasting crisis in classic CAH, and treatment is targeted to replace the insufficient adrenal hormones and to reduce adrenal androgen excess.